Burn station. Before entering the station, you are provided with a diagram indicating the areas affected by burns.
How do you calculate the surface area of a burn?
For adults, the rule of nines is used to estimate the total body surface area, TBSA, affected by a burn. The body is divided into sections, each representing approximately 9%, or a multiple thereof, of the total body surface area. In children, the Lund and Browder chart is more accurate as it considers the changing proportions of the body areas with growth.
How would you manage a burn?
The initial management of a burn involves the ABCDE approach to assess and treat life-threatening conditions. This is followed by calculating the burn surface area and depth, providing adequate analgesia, fluid resuscitation using the Parkland formula, wound care, giving tetanus prophylaxis if indicated, and referral to a burn center if necessary.
Why are colloids not given in burn patients?
In the initial phase after a burn, colloids are not recommended because they do not stay within the intravascular compartment due to increased capillary permeability. Crystalloids like Ringer's lactate are typically preferred.
How would you assess the adequacy of fluid therapy?
This can be assessed by monitoring urine output, aim for greater than 0.5 milliliters per kilogram per hour in adults and greater than 1 milliliter per kilogram per hour in children. Heart rate, tachycardia may indicate under-resuscitation, blood pressure, hypotension can suggest inadequate fluid resuscitation, and central venous pressure, CVP, if available.
What complications can arise from burns?
Complications can occur early or late. Early complications include shock, respiratory distress from inhalation injury, and infection. Late complications include scar contracture, hypertrophic scarring, and psychosocial problems.
What is the definition of ARDS?
ARDS, or acute respiratory distress syndrome, is a type of respiratory failure characterized by rapid onset of widespread inflammation in the lungs, resulting in severe shortness of breath, low oxygen levels in the blood, and diffuse pulmonary infiltrates.
What is the pathophysiology of ARDS?
ARDS involves damage to the alveolar capillary interface, resulting in increased permeability and development of protein-rich pulmonary edema. This triggers an inflammatory response with release of cytokines, leading to further damage, reduced lung compliance, and impaired gas exchange.
What is the PaO to FiO2 ratio?
This is the ratio of arterial oxygen partial pressure to fractional inspired oxygen. It's utilized to assess the severity of oxygenation impairment in conditions like ARDS.
What conditions are associated with the development of ARDS?
ARDS can be caused by both direct lung injury such as pneumonia or aspiration, and indirect lung injury like sepsis or pancreatitis.
What is the Berlin criteria?
The Berlin definition of ARDS classifies it based on timing, chest imaging, origin of edema, and oxygenation. It further subdivides ARDS into mild, moderate, or severe based on the PaO2-FiO2 ratio.
How would you manage ARDS?
Management is largely supportive and includes mechanical ventilation, with low tidal volume ventilation and prone positioning, conservative fluid management, possibly steroids, although use is controversial, enteral nutrition, and treating the underlying cause.
What are the long-term sequelae of ARDS?
Long-term effects of ARDS can include physical impairments like muscle weakness and reduced lung function, psychological effects such as depression, anxiety, and post-traumatic stress disorder, PTSD, cognitive impairment, and reduced quality of life.